Hello, my name is Dallas Holliday. I'm a fourth-year emergency medicine resident at Midwestern University, and today we're going to be talking about loperamide abuse. Brief history of loperamide. It was discovered by Janssen Pharmaceuticals in 1969. Initially, it was a Schedule 5 drug, as some animal studies with high-dose loperamide did demonstrate withdrawal symptoms. However, subsequent human studies at normal recommended dosing did not have these side effects, and it was decided that loperamide had a low potential for abuse, and it was made over the counter in 1988. In 2011, the World Health Organization replaced codeine with loperamide as their treatment of choice for diarrhea in adults on their list of essential medicines. That's the structure of loperamide there, which we're not going to spend a lot of time on, as that is beyond the scope of this lecture. So this is a great example of a study that was published in Clinical Pharmacology and Therapy in 1980, during a time when ethical standards for medical research were apparently a little bit looser than they are today. But essentially, this was a double-blind study of men with a history of illicit drug use but no addiction to opiates, comparing codeine and loperamide. So the patients were given increasing doses of loperamide and codeine, respectively. And then they were basically asked if they liked the feeling the drug gave them, little or not at all, and then whether or not they would identify the drug as dope, quote unquote. Since it was liked by half the subjects and identified it as dope at a frequency less than codeine, it was concluded that it had little abuse potential and would be safe for over-the-counter. And this is one of those studies that actually supported making the medication over-the-counter in 1988. However, obviously, if this were the case, we wouldn't be having this discussion today. So before we talk about the current problem with loperamide, let's review some pharmacology. The brand names are Imodium, and Kaopectate is an older name. Loperamide binds peripheral mu receptors in the gut, as well as calcium channel receptors, to slow gut motility and peristalsis and increased rectal tone. Therapeutic dosing is a 4 milligram loading dose, followed by 2 milligrams as needed for diarrhea, not to exceed 16 milligrams daily. At this standard dosing, loperamide has a half-life of about 10.8 hours, though some studies suggest that this is more like 40 hours with massive overdosing. And it has a low bioavailability and does not readily cross the blood-brain barrier. Additionally, loperamide undergoes P-glycoprotein efflux if it does happen to sneak past that blood-brain barrier. Again, this is all at those standard dosing levels. However, in recent years, it has become clear that people are ingesting super therapeutic amounts of loperamide on the order of 4 to 35 times that of the maximum standard daily dosing. And at this dose, they'll actually overcome the blood-brain barrier and that low bioavailability and result in a central opioid effect. Thus, loperamide has been increasing in use for self-medication of opiate withdrawal symptoms, as well as recreational abuse highs. By studying published research, people have also figured out that these effects can be potentiated by co-ingestion of a P-glycoprotein inhibitor, such as grapefruit juice or omeprazole. Because it's being used to treat withdrawal symptoms, it's actually earned the street name of poor man's methadone. Interestingly, there was a study published in a pharmacology journal where they administered loperamide in one group and then loperamide plus quinidine, a P-glycoprotein inhibitor, in another group, and then measured meiosis and found that they actually had a reduction in pupil size that was statistically significant in the group receiving quinidine, suggesting that taking those P-glycoprotein inhibitors does help or does emphasize or enhance that CNS penetration. And again, resulting in a lot of problems. So what's the big deal? Why are we talking about loperamide now? Why has it been in so much of the emergency medicine literature recently? This issue has really become salient for two reasons. The toxicity of loperamide, and additionally the increase in abuse of loperamide. And we're going to talk about both of those. When we talk about loperamide toxicity, it has effects in the gastrointestinal, CNS, and cardiovascular systems. The gastrointestinal effects tend to be nausea, vomiting, constipation, abdominal pain, maybe some abdominal cramping. There have been case reports where those abusing loperamide presented to the ER for these complaints. So even though it's not going to be top on your differential, because the differential for abdominal pain is, 40 pages long, but just keep it in the back of your mind in these patients, especially in your younger patients, and especially with anyone with EKG changes, which we're going to get to momentarily. CNS is going to be your opioid toxidrome. Generally, unlike our other patients with their opiate overdoses, that respiratory depression is not the cause of death in these patients. This portion of the abuse is actually fairly well tolerated, or at least as far as the current literature, there's no case reports documenting a respiratory arrest from respiratory depression. And the cardiovascular effects are really where most of our problems happen. Unlike heroin and prescription opioid medications, the cardiac toxicity of loperamide appears to be the primary cause of fatality. Cases document ventricular dysrhythmias such as ventricular tachycardia and torsades, as well as QT prolongation and QRS widening. Loperamide is actually a piperidine derivative, which is known to block sodium channels at doses of 6 to 23 milligrams per kilogram, which may play a role in the QRS widening that's seen in these patients. The QT prolongation is thought to be due to the undifferentiated calcium channel blockade. And here's the EKG of a 24-year-old male who was abusing loperamide in a case published as a letter to the editor in the Journal of Emergency Medicine in March 2016. He presented to the emergency room just with vague complaints of feeling weak and was found to have ventricular tachycardia on his EKG. Pretty frightening EKG there, especially with that nasty pause. Would not be happy to see that in the ER. And this was a 28-year-old female who was abusing loperamide. A case report study published in Heart Rhythm. She was reportedly taking 200 to 600 milligrams of loperamide daily to replace her Norco habit, and presented to the emergency room complaining of multiple syncopal episodes over the previous week. And they managed to get an EKG during one of those episodes, and this is what they saw. So again, pretty darn scary. So the other problem with loperamide is that abuse is on the rise. According to National Poison Center data, there was a 71% increase in calls related to loperamide abuse between 2011 and 2014. And this is an image of Google Trend data. So this is essentially the number of times that people were doing Google searches for loperamide over time. You can see there around 2010 or so, there's a pretty significant uptick in how many people are searching for this on the internet. I suspect that little blip towards the end is probably more related to healthcare professionals, since this has kind of been popping up on our radar, but certainly that incline around 2010 was likely not medical providers. And according to the literature, the first documented reported discussion of loperamide for withdrawal symptoms was seen in a drug forum in 2005. So, of course, when I started to do my research, I started where we all start these days, with Google. And as you can see there, those handy little suggestions that Google has for you. When I Googled loperamide, loperamide for opiate withdrawal, loperamide recreational use, loperamide high, those were also those suggested factors suggesting that people have been abusing this. This was a website, Erowid. If you're not familiar with it, it's actually a database and documentation of people's different drug experiences and different drugs they're taking. And you can actually go to their quote unquote advanced experience report database, and you can see loperamide is right there on their drop down menu. And then this is the drug forum. This was a search I did a number of weeks ago, about 6,000 results if you just search their forum for loperamide. And these were pretty fascinating. I mean, I sort of fell down the rabbit hole for hours reading all these posts from people, describing how much loperamide they're taking, what they're taking it with, documenting their highs. And then you'll actually see these people are quoting published articles to support their claims, especially because there is some contention within the drug community whether or not loperamide actually works for a high. It was pretty fascinating stuff. And this is my favorite Google result, which was actually on Yahoo Answers. My butt is on fire. What to do? Luckily, you can take heart in knowing that people are still using loperamide as it's meant to be used, as demonstrated by this result. So as far as FDA data, there were 48 cases of serious heart problems reported to the FDA with regards to loperamide, and greater than 50% of those were reported after 2010, and 10 of those patients actually died. So you can see, greater than 1 in 5 patients dying from this abuse. It's pretty significant, and it's definitely something we need to be aware of. So again, your treatment for these patients primarily is going to be supportive care, especially if they're coming in arrest. You may not know that this is the ingestion, so like our other poisoned patients, supportive care. You can try naloxone or Narcan. This was mentioned in several case reports. However, remember that that's primarily going to be blocking those mu receptors in the CNS. That's not really where the problem is with this. So while it's very useful for someone who's overdosed on heroin and is no longer breathing, it's certainly not going to prevent the cardiac toxicity. Again, you're going to use bicarb pushes for your widened QRS, which can also be a little bit diagnostic because you've got a wide QRS and you start pushing bicarb and it narrows, then that can be somewhat diagnostic. Magnesium for your torsades, of course, and then pacing, either transvenous or transcutaneous, although there have been case reports that have noticed that these patients require a significantly increased amount of electricity to actually capture when you're pacing them. So again, just be aware of this, particularly in your younger patients, your 25-year-old that comes in with syncopal episode or shortness of breath or weakness. You really want to make sure you're getting your EKG. And certainly if you have any of those findings we discussed, such as QRS widening or PR prolongation, you really want to ask them pointedly, if they're taking any over-the-counter medications. Thank you so much. You can find me at Dallas_holiday or email me at dallasholiday@gmail.com if you have any questions or suggestions. Always happy to hear it. And here is a list of references and journal articles if you want to read about this some more on your own. All right, thanks so much.